Good afternoon, good morning, good evening, depending on what zone of the world you're in. Welcome to day 2 of the annual conference for Women in Global Health Norway. We are about to begin and we have a fantastic lineup of speakers today. We have 2 sessions today. The first one, as you can see on your screen, will be focused on safety and security of healthcare workers during the COVID pandemic and other epidemics. We will have some keynote speakers and time for some questions and answers from the audience. And then we'll move on to session 4, where we'll be exploring challenges for women in global health careers, what we call broken rungs in the early stages and glass ceilings in the last stages. So we'll have a lively panel discussion, also with Q&As from the audience. And then please stay with us for some closing remarks. With that, I want to introduce our moderator for session 1, Anna Stavdal, who is the president-elect of WONCA World, so the World Organization of National Colleges, Academies, and Academic Associations of General Practitioners or Family Physicians. So Anna will be moderating session 1 for us. Welcome, Anna.
Thank you so much. And also thank you for really reading out the full name of our organization, the World Organization of Family Doctors. And good morning, good afternoon, and good evening, wherever you are. Thank you for the opportunity to moderate this session on safety and security of healthcare workers during the COVID-19 pandemic and other epidemics. We can say that the COVID-19 crisis works as an amplifying glass, making gaps and shortcomings in healthcare and leadership more visible. The health workforce is key, and as we speak, we observe the health workers are exposed to lack of personal protection equipment, stigmatization, even violence, and the risk of burnout of health workers is increasing as the pandemic goes on. The global health workforce is not inexhaustible, and the majority of healthcare workers globally are women. In many countries, politicians and the general public have literally applauded healthcare workers for the job we do. But that is not enough. Now it's time to change the narrative from tales about heroes or heroines to action. How to maintain a resilient workforce, how to provide protection to health workers, the majority being women, with safe and decent working conditions. How can we improve safety and security of frontline healthcare professionals in this pandemic and in future health emergencies? How can we use lessons learned to enact meaningful change? To help us explore and reflect on this challenge, we have 3 very competent speakers, and it is now my pleasure to introduce the first one out, Dr. Rupa Dutt. She is Executive Director of Women in Global Health. So let me start with thanking you for your invaluable efforts. In 2015, you were one of the co-founders of Women in Global Health. A practicing internal medicine physician, you're a passionate advocate for gender equality, a leading voice in the movement to correct the gender imbalance in global health leadership. I'm particularly committed to addressing the issues that keep many women from global health leadership roles. Thank you, Rupa, for your tireless work. Now the floor is yours, and I will help you keep time. We will look at 20 minutes from you now.
Great.
Great. Thank you, Anna, for a warm welcome. And it is really great to join all of you again on day 2 of this amazing summit, and the topics that you have picked and the deep, reflection on not only looking at women's leadership, but really looking at, what we really need to be doing in the health sector and social sector to ensure that the workers that are holding up the health systems have decent and safe work conditions is of critical importance. Of course, the pandemic has, as Anna, you have mentioned, a magnifying glass on what the inequalities have been. It really is also time for us to not just reflect on these inequalities, but take these data points that I'll be sharing and others today to think about how can we transform the health sector so it is much more equal. It is providing safe and decent work conditions for all health workers, and especially the invisible health workers, the invisible essential workers that hold up the health system too. So I'll be focusing a bit on really the health worker challenges that we are seeing, especially around the issues of safety. I'm just going to pull up my screen here. Okay. Great. So again, I'm speaking on behalf of Women in Global Health today, and my topic is really going to be focused on COVID-19 and women in the health and social workforce. Women in Global Health co-chairs a gender equity hub with the World Health Organization, so some of these data points are also coming from the community of the Gender Equity Hub. As you have probably heard this entire summit, is that global health is delivered by women and led by men. And just to show you how glaring this issue is, when you take a look at the leadership pyramid in global health, 90% of the long-term care workers, which are part of the health system, but not always counted as part of the health system, are women. And as you go up that particular, ladder and up the pyramid, what you'll notice is that women are represented less and less, especially when there is political decision-making happening and in the private sector. And this actually has consequences, and we're seeing those consequences being magnified here in the COVID-19 pandemic. And just to highlight that we can't only talk about this issue from a gender lens, we really have to look at this from an intersectionality. We also know it is often the poorest women that are subsidizing healthcare around the world. And we also know that, women that are coming from low resource backgrounds, LMIC countries, are the least represented in global health decision-making, and that does shape our global norms. Particularly global health security does depend on women, and this is something that we have been really bringing a spotlight during COVID-19. Just to focus on, if we imagine the women health worker, and specifically what are some of the challenges that women health workers are facing and experiencing, number one, it clearly is the fact that they are being applauded, so there is a lot of pride and professional satisfaction that they are playing a critical role for health, society, and global health security, but this does come at an expense. And the expense is related to personal safety foremost. Number one, there is a high risk of infection. We know that early on in the pandemic, it was quite apparent that physical protective equipment, also known as PPE, was inadequate, one in shortage, but also in the fact that they were designed, PPE equipment was designed really to fit male bodies, so larger body suits, larger face shields, not necessarily fitting the physical frame of all women. When we also know that this has impacts in the fact that the more infections that health workers are getting, not only are they at risk personally, and we have heard of cases of health workers having lost lives, and women nurses at the front line especially being very vulnerable, but also women community health workers around the world that remain often unpaid and underpaid. But there's also risk of infecting family, especially vulnerable relatives. Women have been asked around the world in every society to take on more childcare responsibilities, to take on elder care responsibilities, but also taking care of communities. And there is a burden that women health workers carry about whether or not they're bringing the infection back home to this family. And as a practicing physician, I can say that this is a conversation that especially us women physicians have often had about, do we see our elderly parents? Do we, think about how we can further isolate, when we're coming home, and do extra protective measures? And these are real questions. And what I've seen is some of the colleagues have, especially especially the women colleagues, have taken extra measures to wear extra layers of physical protective equipment, practice more quarantine efforts, and really limited their social bubble even more so than what the public health requirements are. And again, these are case examples, but we know over and over again that women are not only thinking about their own health, but they're also thinking about really the risk that they have infecting others around them too. We've also seen a spike in, particularly when it comes to health worker safety from physical violence. As you have heard at the summit, that there has been an increase in gender-based violence altogether. The numbers have gone anywhere from 30% to 40% in countries that have taken a look at the spike in hotline calls. Several governments have responded in innovative ways, including setting up emergency shelters and supporting women in physically separating from the space of violence. But health workers, they do not have an option. Their job is to be at the front line, and that front line includes often being exposed to violence. And that violence comes from really three groups. One, this is not a gender war when we talk about gender dimensions, but a lot of the violence is perpetuated by men both from a physical harassment, sexual harassment, and bullying. Surveys that were released, including the report that was released on the status of the nurse this year, shows that nurses face an extreme amount of violence and bullying. We also know that the Delivered by Women in Health report showed that the national surveys we were able to access around the world showed at least 50% in some places, and even upwards, that women were facing harassment and violence and bullying in the workplace. We know that this violence also comes from patients. Patients are, and patients as people, so as community health workers are going out into communities that are affected by the pandemic in extreme ways, especially where there are settings of extreme poverty, we know that there is a lot of anger and not a place to displace that anger. And often the health workers are seen as a source because they symbolize health, but then they also symbolize the virus for many. And so we know that, community health workers are facing violence from their communities too. And at the bedside, we know that for a long time, patients, for multiple reasons, especially with the frontline health workers, nurses and midwives particularly, but also women physicians, face verbal abuse, physical abuse, and all of that is being heightened in COVID-19. And this is not something that's new to the COVID-19 pandemic. It is something that we have seen in previous disease outbreaks and research that's happened around Zika, as well as research around Ebola. Building on that, some of the other realities is that we know that women in the health workforce are often powerless. They do feel this sense of powerlessness, not being able to shape decisions making in health systems, not able to allocate resources, especially resources that might be needed to provide more protection, both the physical protection, but also the personal security. And third, the psychosocial support. Too often, the resources that are being invested are really focused on the technical approach to COVID-19, detecting the virus and contact tracing and really doing public health outreach around that, but we don't take care of our health workers. And if we don't take care of them, how can we expect them to really provide care and provide, be there fully in their full selves, fully supported to do the best job that they really can. So we have unrealistic expectations. We already know that health workers, particularly women health workers, are the shock absorbers of society, and that has an impact on them personally, but it also has an impact on our health systems, and it weakens our health systems when we don't factor this in. Some of the other things that we are seeing around the realities for health workers is the stigma. We know that in some communities, particularly health and social workers and other essential workers that might be highly exposed to the virus, are stigmatized and are pushed away from some of the social gatherings that are essential even during the COVID-19 times. We know as people we need to have socialization, but health workers are carrying a stigma in many places as well. I've also talked about the mental stress, but to be very specific, we know that health workers are facing increased amount of stress. This has led to increased mental stress and an emergence of PTSD, so post-traumatic stress disorder, a higher risk of depression and suicide. There have been reports looked at in the spike of suicides, particularly in the Central America area. We know that if we don't invest time into providing psychosocial support, that mental health can worsen, and in a pandemic, it's going to be clearly heightened since a lot of the burden is falling on the health workers. They have also long hours, exhaustion, and they have to manage domestic work, but this is really falling disproportionately on women health workers more than male health workers. I'm sure you have also heard about what impact it's had on the career aspect too for those women health workers that are also involved in research and other career professional opportunities. Women are leaving the workforce. They are having less productivity because of the fact that the structural barriers are not acknowledging that women have added care responsibilities. And finally, there is a financial hardship too. Many women health workers are already underpaid and undervalued. And now we're seeing those numbers even go up. The health sector is already known to be one of the sectors with the widest gender pay gap, averaging around 29%. But in COVID-19, we know these numbers are going to be going up. And as I shared in my opening remarks, women provide $1.3 trillion US annually in unpaid care to the health and social sector. And again, that's 1.3 trillion, which amounts almost to the GDP of the size of a country of Mexico annually. So these are not small numbers, these are very large numbers, and it's half of what women do in the health sector. So imagine what would be possible if we turned the applause. Clearly, we know health workers are providing essential care and services, and they really are holding us up, and they're the shock absorbers of society. But what if we could really turn this into gender transformative policy action? And that's really what Women in Global Health is calling for in our 5 Ask campaign, and it's part of our work in the Gender Equity Hub that we co-chair with the World Health Organization. As mentioned, women in health, applause is great, but safe and decent work is better. Particularly breaking down the data, we know that data gaps are still quite wide, so we don't have good data on how many health workers are being infected and how many of them are women. But an example is here in the United States, 73% of the infections amongst health workers are women. We know that there's very similar data that's coming out in many other countries, including Spain as part of the database that UN Women has. But as far as how many countries are reporting, globally, we know it's less than it's approximately around 50 plus countries that have sex disaggregate data, but we know that the health worker infections are less than a dozen. So this is a call for data as well. We must apply an intersectionality lens. This does not just apply in countries where there are racial minority groups. This also applies in countries where there's other ways that look at minorities. So migrant groups are especially exposed to the disease more than others. And some numbers here in the United States show that Black people account for 21% of the impoverished population, and they have in some cities up to 4 to 5 times number of infections, even though that they only represent 1/10 of the population in that city. And again, the message, applause is great, but we really must turn this into safe and decent work. And particularly on the issue of violence, I'd like to emphasize that there are solutions, and these solutions really begin at making sure that we engage men on the fact of gender-based violence. So this should not be women having to address gender issues, but it really should be everybody's business, and all genders involved and all levels of decision making. We need a Me Too movement in global health. We need a Me Too movement times up in health in every country, because the harassment and violence is real, and it's not just in the pandemic. Second, we really need to work with our systems. So our health systems should really be having not just policies, but programs to address the violence and harassment, and allocating resources to address this. And finally, there's also the community aspect too, where we need to educate our patients, our population, and our communities to not deflect their frustrations toward health workers. And in closing, I'd really like to emphasize that until we start valuing our health workers and compensating them and paying them equally, we know that there is going to continue to be a ripple effect. If we were to formalize all health workers and social workers around the world, not only would that lead to economic growth, but it leads to the triple gender dividend, which is a health dividend, a gender dividend, and a development dividend. So we really should look at these issues as an investment to broader societal health and well-being. So some of the key messages, I'm not going to be reading these, but these are going to be available to you, but I'd really like to drive home that we have an opportunity in the Build Back Better time. Right now, we are calling for a new social contract. The women who deliver our health and social care deserve a new social contract with decent work conditions and an equal role in decision making. If we look after our health workers, which includes all health workers, but especially women, they will keep us safe. And there really is an opportunity to bring this to the light in all settings, particularly as you are members of the Women in Global Health Norway chapter. Norway is a country that is very committed to health workers and also gender, and we know that they can do a lot more. They already are doing an immense amount, but the more you can mobilize nationally and national actors, but also look at global opportunities. We are at the 25th anniversary of the Beijing Plus 1995 Declaration, and next year the governments of Mexico and France will be hosting a Generation Equality Forum, and one of the action coalitions is exactly on the theme of economic justice, but we do not yet have a platform to bring visibility yet on women and health and women and the health workforce. So let's not only think about women from the perspective of vulnerable populations or targets of addressing public health disease interventions, but let's look at them as change agents that we must invest into. So on that note, I'd like to turn it back to Anna. Thank you, and looking forward to engaging with you throughout the rest of the discussion.
What a start, Ropa. Thank you so much. You're really outlining the main perspectives in this discussion. I think we are both clinicians, and listening to you, you said we must educate our patients also in this perspective. Can you share a little bit of your ideas, how to do that? Yeah.
Yes, Anna. So, particularly when it comes to patient education, too often we are, focused on the disease aspect, and then the more and more, as our field has evolved, we've talked about motivational interviewing, really empowering our patients, being patient-centered. But I think a part of that is also defining the physician and patient relationship, the nurse and patient relationship, and making sure that the values of dignity and respect are mutual. And so I think there really needs to be, as part of this social contract, more that we do when patients engage our health system, being very clear what that respect looks like, and that is not only a respect in the to address deference. It's more about really respect, so that everyone involved in the health system feels safe and can do the best to get the best health outcomes for everyone involved. So I think really making it an aspect of this is how we will have better healthcare. We know that if health workers were compensated more, they would be less frustrated in their jobs. If they were having better working hours, more flexible hours, we know there are tensions that happen at the bedside, but have we really taken the time to also look at, are we providing our health workers with the support that they need? And patients, of course, have very good reasons for why they might be violent or frustrated, or they might be in a state of delirium. But all of those things, we could do a lot more to educate patients and families, and also, direct some of those frustrations in more constructive places. So I think really beginning with conversation and communication first, and second, really redefining that relationship to be built on respect that's mutual, and coming to a new social contract that it's clear it's not only about how we treat each other, but it's also about providing better health and better health for everyone.
Thank you. Another comment or reflection on my side, which occurs every time I discuss gender and healthcare, how to engage males in this effort. One thing is composition of the workforce. I think it's healthy to have a good composition of the workforce, but how to engage males in this?
Yeah, great question. I think there are definitely many ways in Women in Global Health. The first thing what we've done is we've created a movement where we say that, it is clearly a platform for women, but also for all allies. And what that means for us is all other genders that really, see that, we have a lot of work to do when it comes to gender equality. And that is areas where women are currently being marginalized. And so there is a role for those in power to use their power to restructure systems. Second thing is mindset. Too often we, men don't quite realize always that gender equality benefits them. So the more we can have conversations saying that actually, and I think the Nordic region is often cited for examples of this, but I think this is something that more and more around the world we're seeing is that we know when there's gender equal societies, then men are able to take paternity leave, they're able to participate in family care. It actually deepens the bonds, and it actually deepens the family bonds, and it changes their perspective as well. And it provides, much more, I think, engagement and fulfilling lives as well. So I think we need to talk about this, that men are missing out on family life as a result of the way that society is set up. And the amount of pressures that we have from harmful masculinities, COVID-19 is a prime example. There are clearly many theories of why men have died at higher rates or have had higher infections. Some of them is clearly the fact that we don't have very good data. And the second is, access is biased toward men getting more screenings in many countries than women. But the other bottom line is there's harmful masculinities that are impacting men's health. And the fact that they might be coming and approaching health systems at a later stage. And we know that the report released by WHO at the last World Health Assembly in 2019 showed that starking data that on average, women are living longer than men, but of course, women are often living in with what we say is like they have other, social determinants of health, but also other inequalities such as living in poverty and with less political choice, less freedoms. But those are examples where we really need to get the mindset clear that if we are to approach health and well-being, and this pandemic is a prime example, that when we're gender blind, we're actually doing a disservice to all of society, to all of gender, and not just the health sector, but also our economic well-being. So really approaching it from the mindset. And I think the third part is really around, co-creating the solutions. We often talk about the values of being collaborative leadership that women in general, sometimes that is due to the gender norms that women are being raised around, but there's theories around whether it's nature versus nurture. Regardless what it is, we do know that women leaders in general have been more collaborative, and certain countries that have embraced a feminine way of leadership tend to be more collaborative. But the more we can say that, when we have diverse teams, it leads to better solutions, and we can co-create the solutions, we can understand the solutions. It leads to a multiplier effect of dividends, and that does include better solutions, more sustainable solutions, but it also leads to more ethical decision making. So there's a lot of really great work that's being done, but I think we don't necessarily take the time to have these discussions, and we do have to be as comfortable as women to create space for men and be intentional about it, and not that the burden should be on men. Should be on women to do this, but I think we are the ones that are the leaders in this space, and we can be more intentional. And of course, I think that this is something that needs to be a continued discussion. We have a lot more work to be, a lot more work that needs to happen. But we are delighted at Women in Global Health that we do engage with men's health organizations around the world, and have been able to, amplify both of our respective messages. So for us, it's not a gender war. It really is very much about, gender equality, understanding an intersectionality lens leads to better health outcomes.
Thank you so much. A very rich reflection, which I submit to completely. And it's important to keep that part of the discussion going. We will move on now to our next speaker. And we will get back to Europa in the discussion, I'm sure. Our next speaker is Amanda McClelland, Senior Vice President in Prevent Epidemics. She has more than 15 years experience in international public health management. Previously, she served as Global Emergency Health Advisor for the International Federation of Red Cross, where she focused on emergency health, epidemic control, mass casualty in low resource settings, disease prevention, and response operations. She is an operative. And now, Amanda, the floor is yours. Welcome.
Thank you so much, and good afternoon to everyone in Norway and anyone else joining from around the world online. And I just want to thank the organizers for inviting me to this event to highlight the issue that is really close to my heart, but also that I feel is a core part of my professional responsibilities. My name is Amanda McClelland, and I'm a registered nurse. And it feels good to say that out loud. Although I've been a nurse for more than 20 years, my normal introduction, the one that you just heard, is quite the mouthful, often done not necessarily to emphasize that I am most likely the only person in the room that is not a doctor. My normal introduction would have been Amanda McClelland, Senior Vice President, Prevent Epidemics Team of the Resolve to Save Lives and Initiative of Vital Strategies, in part emphasizing my role as a public health leader. But if you'll indulge me for today, I would really like to speak to you as a nurse that has spent the last 15 years responding to humanitarian crisis and epidemics across the globe. A nurse that recognizes we've not done enough to advocate for and protect our own profession and the healthcare workers we work alongside. Not just in the global south, where I've lost many colleagues in disasters and epidemics, but across the globe. As a nurse, a profession that is revered as an advocate for patients, we now find ourselves in a position of caring for our own in numbers that are sometimes too large to fully grasp. If we are to make change, now must be the time. Healthcare worker health and safety is not a new problem, but it is one that we can solve. In 430 BC, as the Athenians suffered under a Spartan siege, a plague arrived. The plague reoccurred over the course of 5 years, killing as much as a third of the population. A description amongst the oldest written accounts of an outbreak identified the key horrors of outbreaks that we still suffer today. The healthcare workers tasked with caring for the ill were at the greatest risk of becoming ill and death themselves. Nearly 25 centuries later, we have the technology to protect healthcare workers and identify the causes of illness to target interventions, and yet we still fail to keep healthcare workers safe while lionizing them as heroes. The bottom line is this is not a new problem. It seems it's not even one we've really tried to address despite the multitude of examples through history. There's no standard reporting system to even count the number of infections and deaths, as Rupa pointed out. In a recent literature review that we undertook to really capture the scale of the problem in outbreaks, we were unable to even find basic data, including the economic analysis related to the cost of healthcare worker infections. Without accountability, economic justification, or sustained professional and political leadership, the lessons of past epidemics continue to repeat themselves, and women bear the majority of the burden. There has been global leadership, especially from women in the past, including Florence Nightingale from the 1800s. Women, the large majority of the health workforce and the most impacted by the negative consequences of health and safety, are missing in key leadership roles and needed to implement and sustain change. Women leaders have stood and made progress on this issue. While the Spartans identified the problem of healthcare worker infections in the 5th century, Florence Nightingale, born in 1820, is credited with introducing or advocating for key aspects of infection prevention and control practices. While nursing was not seen as a path for the well-educated, Florence defied stereotypes and managed a hospital during the Crimean War. She was horrified at the death rate and focused on improving the environment to improve outcomes. Back in the UK, she used cutting-edge data analysis and visualization to advocate for improvements in healthcare, particularly around sanitation and hygiene issues. Her work to improve healthcare outcomes included environmental controls like design changes in hospital and hygiene practices that in part are still used today. But let's skip ahead from the 1800s to today. The novel coronavirus arrived in late 2019 and spread like wildfire. In just over 10 weeks from the initial report of the outbreak, COVID-19 became a global pandemic. Overstretched healthcare workers were frequently shown moral support, as we've discussed, including in the United States and the United Kingdom. And yet there have been tens of thousands of healthcare worker infections, suicides from the strain of ill-prepared public health systems, and an unacceptable mental health toll. Several weeks ago, Amnesty International reported that more than 7,000 healthcare workers have died fighting COVID-19, with huge numbers in Mexico, healthcare worker infections in the US totaling more than 1,000, and the UK and Brazil leading the way. A recent study by the International Council of Nurses across 32 countries accounted for a much higher figure. More than 572,000 healthcare workers had been identified as being infected by COVID. And the data showed an average of 10% of all COVID-19 infections in a country were actually healthcare workers. If that proportion were repeated globally, at the time of reporting, the true figure of healthcare worker infections were more likely in excess of 2 million. Data from Africa on healthcare worker infections is also not complete, but amongst 42 countries that the WHO Africa region was able to get data from, more than 41,000 infections were counted, the vast majority coming from South Africa, which has had more than 27,000 infections and 240 deaths. Healthcare worker deaths and infections are not limited to pandemics. The 2013-26 West African Ebola outbreak disproportionately impacted healthcare workers, who were 21 to 32 times more likely to be infected than the public. All told, the three most impacted countries suffered more than 881 infections in nurses, doctors, and midwives, and more than 514 deaths, accounting for 8% of the total health workforce in Liberia and 7% of the total healthcare workforce in Sierra Leone. The world's lack of preparedness for outbreaks and the refusal to adequately invest in the protection of healthcare workers is a failure primarily of governments, but also international institutions and donors. It's taken an unacceptable toll on healthcare workers, which is first and foremost a personal and individual tragedy faced by so many. If we've known the issue and the impact for so long, why as a profession and a group have we not done more to advocate on our own behalf? Infections in the workplace during an outbreak is a risk, but it's a manageable risk that can be all but negated with investments in training, improved supply chain, and policy change. We need to prioritize action, and if protecting ourselves and our colleagues is not enough of a reason, then advocating for patient safety and communities should be. When healthcare workers are at high risk for infection, there is also a greater risk that they can be at the center of super spreading events, often infecting vulnerable patients. This is particularly problematic for a disease like COVID-19 that can be asymptomatic. There have been several documented super spreading events from healthcare workers for COVID-19. But beyond that, there's very good evidence that several Ebola outbreaks were really driven by initial healthcare worker infections. Both the earliest outbreak of Ebola in 1976 and the recent large-scale outbreak in West Africa reported high rates of infections in healthcare workers, as well as identifying them as key sources of transmission, amplifying the outbreak in many areas. Healthcare worker infections and super spreading events play major roles in transmission of SARS and MERS. During the 2002-2003 SARS epidemic, healthcare workers accounted for more than 21% of all infections. The number of deaths remain unknown due to lack of standardized reporting. Healthcare workers responding to the Middle East respiratory syndrome, which emerged in 2012, have made up more than 20% of the cases and represent more than 3.2% of the deaths. As disturbing as these figures are, the actual tolls, as we've said, are unknown due to lack of consistent reporting. But the number of infections and deaths are a stark reminder of the personal cost that's only reflected in a fraction of the impact of the healthcare worker infections here. When healthcare workers become sick and unable to work, or they leave the profession due to stigma or stress, it further reduces the availability of critical essential services during times of epidemics. During the COVID-19 pandemic, there has been more than 10,000 cases among healthcare workers in Africa. This has put increased pressure on already strained systems. Their shortages have led to critical issues in the supply of life-saving essential services. In countries all over the world, we have seen postponed vaccination campaigns, fewer in-facility births, and some facilities have closed altogether. In Sierra Leone, following the Ebola outbreak, the loss of healthcare workers translated to a 23% reduction in overall health services. We know what must be done. Healthcare workers are heralded as heroes, but asked to work in conditions that endanger them, their patients, and broader populations during outbreaks and in carrying out day-to-day healthcare. We must move from placing individual risks on healthcare workers to a collective responsibility for their well-being. We must accept collective responsibility to protect them, and that won't happen until there is a greater number of women, including nurses, to reflect those that are the most impacted by the risk in key leadership roles, influencing and driving evidence, budget, and policy decisions. But beyond more money and better policies is influencing practice, and we are in control of what we do on a day-to-day in the wards and in the communities. The practice used to prevent outbreaks in hospitals falls under two broad categories: water and sanitation, WASH, which is the presence of water, sanitation, hygiene, waste management, and effective cleaning in health facilities, and infection prevention and control, or IPC, which includes the proper use of personal protective equipment. Taken together, the effective implementation of WASH and IPC practices prevents transmission of hospital-acquired infections, keeps patients safe, and keeps healthcare workers from becoming patients themselves. It's not good enough to turn these practices on and off when at risk change. These practices must be implemented every day, not just in reaction to the pandemics that we are seeing at the moment. They're a necessary prerequisite to providing modern medical care, helping hospital patients avoid new infections unrelated to the reasons for their visiting the hospital. They also make it possible for healthcare workers to go to work and serve the population with decreased fear of becoming ill themselves. Safe health facilities and safe health workforces are a minimum standard that should be held, that governments and partners should be held to account for. The recent experiences of healthcare workers during COVID-19 pandemic have demonstrated the persistence of inadequate WASH and IPC, what we should consider the basic levels of preparedness. A recent survey, even here in the US, more than 23,000 nurses were surveyed, and more than 27% reported caring for confirmed COVID patients without the appropriate level of PPE. More than 84% had continued to work after exposure and had yet to be tested. We need to acknowledge that this is a global problem and not confined to limited resource settings. Every day, the lack of adequate IPC practices and WASH, the lack of adequate training, makes patients sick, takes many lives, and has enormous economic cost. In times of epidemics, these same dynamics make healthcare workers sick and take their lives and the lives of those they try to care for. But we would be remiss if we limited our review of the impact to just the physical well-being of healthcare workers and their patients. The psychological impacts of outbreaks, the constant stress of being under-resourced, and feelings of being overwhelmed during the pandemic is taking perhaps even a far greater toll. Even in normal times, healthcare workers are at high risk for mental health issues and are more likely to miss days from work than any other sector. It's a difficult job at the best of times, but in outbreaks, the everyday stresses of being a healthcare worker are amplified, further negatively impacting mental health. A recent study from Hong Kong characterized the main issues impacting mental health as being resource constraints, fear of cross-infections, ongoing dynamic changing protocol, and the care practices being provided. The ethical obligations many healthcare workers feel to their professions and their patients are rooted in an obligation to continue to work despite a fear of safety and re-emphasized as being hailed as heroes, at least by some. Despite the many visual displays of support for healthcare workers across much of the globe, many healthcare workers facing large amounts of stigma and violence. By one account, 69 healthcare workers have been killed and 34 kidnapped related specifically to COVID. In some countries like the US, public health officials and those working to contain the outbreak have been demonized, attacked, and their lives threatened. In India, healthcare workers have been stoned and evicted from their homes. And in the Philippines, a nurse was attacked and had bleach poured on his face. The Healthcare Danger Initiative that was created by the International Red Cross and Red Crescent movement aimed at addressing the issues of violence against patients, health workers, facilities, to ensure safe access to and delivery of healthcare in armed conflict and other emergencies. In a recent report focused on COVID-19, they reported more than 600 violent incidents recorded against healthcare providers in more than 40 countries. Healthcare workers are often not only on the front line against the disease itself, but also the stigma and fear motivated by the disease. As we've said, this is a problem we've known about since Sparta. It's not just a COVID problem, but it's a pattern in every major infectious disease outbreak that we've seen. This is not just an issue for nurses, but all healthcare workers, from administration support staff to community healthcare workers to intensivists. It's not just a lower middle income problem, but one that is impacting the global north at potentially even higher rates. We know the issue and we have the solutions. We are just not adequately and consistently applying them. Given the scale of the crisis, what makes this a woman's issue? And Rupa really set that up for us, and you've been hearing about it for the last few days. But we know that women hold 70% of the jobs in the health workforce, but only 25% of those leadership roles. And that is amplified in crisis. We don't have a seat at the table to prioritize the practical issues that we see on the day-to-day basis within patient care. The impact on illness, mental health, and stigma is disproportionately affecting female healthcare workers. These points are things we all know anecdotally. Front lines are full of women and the senior level boardrooms are not. This is true as much as it is in COVID as it was in 1976 for the Ebola outbreak in DRC. Epidemic response must be gender sensitive. Issues from ability to autonomously access care to exposure risk are impacted by gender. Representation matters, and those who are most impacted by a problem should be part of the decision-making on how to respond. Epidemics don't just impact women in formal health positions. Women are expected to be caretakers and often bear the brunt of informal health support without proper training. In order to have greater representation of women in response, there has to be a greater acceptance that there is a gender equity problem in the field. The challenges faced by healthcare workers, particularly those on the front line against disease threats, are not new. They are also not unsolvable. Ensuring healthcare workers have safe work environments protected from infection and violence will only happen when they have a seat at the decision-making table. We need greater representation of women and nurses at the helm of organizations, crisis response teams, and governmental bodies tasked with their support. These issues will only be fixed when healthcare workers are valued and prioritized and roles that have been historically undervalued as women's roles are given their proper respect and protection that other workers take for granted. Healthcare workers are professionals, not heroes, or at least they shouldn't have to be. Thanks, Anna.
Thank you. Amanda, you mentioned the lack of accurate data on healthcare workers' infections and deaths. Can you elaborate a little bit on what role would improved reporting have?
So I think it has to come from accountability. At the moment, we're working with several countries on a new WHA resolution to make it mandatory as part of IHR that we report healthcare worker infections. And so I think there's a lot of WHO guidance on this. I think there's been a lot of work across organizations to call for action. But until we create that accountability mechanism and enforce countries to report infections, they won't take the time or the effort to build the systems that we need to really capture the scale of the problem.
Another thing that came to my mind, we're speaking power and looking at it through the gender lens. Other power structures are the one within the healthcare system between health professions. I highly appreciate what you said before you started your talk. I would like to speak to you as a nurse, because that's what you are. And I appreciate that very much. So that is why I dare to ask you this question. If you add the two perspectives or two elements, one is gender, the other is health professionals within the healthcare system. Where does it lead us? What does it look like within your profession between males and female nurses?
Yeah, and I think to Rupert's point, we don't want to create a gender war in the same way we don't want to create a profession war, but there is definitely a siloed approach to nursing and often seen as a lesser profession. It's a problem for me when I work in specific countries. If I introduce myself as a nurse, I don't get to sit at the table. When I work at WHO, I represent on a number of meetings and panels. It's automatically assumed that I'm a doctor, and then I'm in this difficult position. Do I cross the doctor out on my nameplate and kind of own that I'm not a doctor, or do I make a deal out of it? And I think in part, the fact that epidemic infections, by the large majority, the burden is on nurses, that direct level of care is part of the reason that it's been under-resourced. They're seen and nurses feel it's almost that they have to accept it. It's part of that care for patients, and it's part of that mental stress, that the profession is really driven by that connection with patients and the emotional burden of providing support for patients and perhaps making or doing procedures and care that other parts of the health workforce don't do despite the risk. And it was a huge challenge for me in West Africa, Ebola, when I first arrived into Sierra Leone early to support a hospital called Kenema. They lost 54 nurses in 3 weeks, and their colleagues kept turning up to work. And so, it's this amazing commitment that I think the profession has to caring for patients that puts them at greater risk, but has also made sure that they don't necessarily speak up for themselves. And so this is why we're trying to make it not just a healthcare worker issue, but a patient safety issue. And also part of the driver of epidemics to make that economic argument. When we speak to ministers of health, we don't necessarily speak about protecting healthcare workers. We speak about preventing the spread of epidemics. It's cost effective because healthcare worker infections really drive those outbreaks. And so I think helping nurses see this not as asking for more resources for themselves that they're taking away from patients, but really helping nurses understand that this is about patient safety as much as it is their own safety.
Thank you. To all of you, there are some questions coming in, but we will now, before we go to the discussion and get back to the questions from the audience, I'll for now thank Amanda and Ropa. Before we go to the discussion, we will have a commentary from Kristin Bergtora Sandvik, professor at Department of Criminology and Sociology of Law at the University of Oslo. Kristin's research agenda focuses on the development of a political and legal sociology of humanitarianism. That was a hard word. Her research combines top-down and bottom-up perspectives on the development, role, and place of legal norms, legal categories, legal identities, and legal claims making in conflict and humanitarian action. She will now share her reflections on the challenges, risks, dangers described by our keynote speakers. And she will do that in a legal context. So please welcome Kristin.
Thank you, Anna. Pleasure to be here. Can you now see my my screen? Excellent. So my little intervention, and I've been sort of busily regrouping the PowerPoint as you've been speaking. Thank you for excellent and very informative presentations. So my contribution is to think about how we can frame harm through law. So essentially, the speakers have mentioned that, you know, this is not trivial, it's lethal. It's not inevitable, it's political. And it's not a local problem, it's a global problem. So my 5 cents is that this is not incidental, but also illegal. The speakers have showed that women are underpaid as healthcare workers, undervalued, that personal protective equipment is not, or very often not, appropriate for women. That for women healthcare workers also in quarantine, care is not taken to make sure that they have a safe and dignified working environment. Sexual harassment is still the norm. My sector, the humanitarian sector, has been through a fairly, not half-hearted, but difficult aid to moment where we had to realize, I see my connection is unstable, where we had to realize that women, humanitarian workers, were also at risk from their bosses and colleagues. And that was a very difficult moment. Increasing need to acknowledge that healthcare workers are victims of sexual violence and sexual harassment. That healthcare workers die on the job, and that they might die on the job because they're women. And in the terms of COVID-19, that accumulated consequence of all of this is risking health system collapse. So it was mentioned that, you know, it's not only the pandemic itself, but it's also the stigma and the specific roles that women healthcare workers have as shock absorbers, and the particular role of discrimination in all of this. It was also important to emphasize the intersectional issues here, that different groups of different women healthcare workers face different issues, tangled up with race, class, religion, and another ethnicity, sexuality. And that at the heart, this is about healthcare workers' right to life and to health. And the question about the right to family life. If you as a health worker is at risk of infecting your relatives and vulnerable family members. And then there was a discussion about how we understand work and this idea of, you know, unpaid labor as is almost invisible, enumerated, and certainly under-regulated. And the question about what we do with this as a systems, right? So how do you fit women's rights with a problem that's faced by an entire health system? I mean, how do we think about individual rights and the whole of the system that needs to change? I thought you did a beautiful job of sort of summarizing this, the challenge of a duty of sacrifice professional culture and a societal expectation, which is I think, as Anna was also emphasizing, tangled up with the fact that most nurses are women. It's this duty to sacrifice. And it's not a new problem, as Amanda emphasized, and it's certainly a global one. It's not one limited to low and low middle income countries. But important thing here is that this is a problem or a set of problems that has identified solutions. And who's responsible? I mean, we're talking about collective responsibility, but also the need for political leadership. And so I guess Rupa was calling for a new social contract, and I think that's a brilliant way of framing this. We need a new way of contracting, not only the relationship between caregivers and patients, but what it means to be a professional caregiver when you can have something like COVID-19 arriving. And of course, when all you got is a hammer, everything looks like a nail. This is the plight of the legal scholar. So when I was reading up for this seminar, there are a lot of talk about standards and regulations, but I don't often hear this problem or see this problem written about as a gendered risks, as a type of human rights violation. So the principles of equality and non-discrimination are the foundations of the rule of law. And in the International Convention for Economic and Social and Cultural Rights, Article 12, it says that everyone has the right to the highest attainable standard of physical and mental health. In the humanitarian law field and with the International Committee of the Red Cross, there's been very significant emphasis on the need to protect and respect medical workers in conflict. And a lot of reporting on what happens with vaccination workers, paramedics, nurses, etc., etc. And there's a UN Security Council from 2016. But what about the context that it's not a conflict, it's a pandemic. And it's a pandemic like the world has never seen before. So Ebola was local, HIV/AIDS was slow moving. This is quite a different one. So how do we think about this normatively? And again, what sort of platform? Ropa was saying we lack a platform. How do we articulate this platform? I guess my pitch would be the Convention on the Elimination of All Forms of Discrimination Against Women. CEDAW is a difficult conversation to work with. A lot of countries have not ratified, a lot of countries have objections, or they have, articulated their objections in ways that render a lot of the content meaningless. But it's still a legal instrument, and it's still, I think, the best we've got. So CEDAW Article 11, for example, has a clause on equal pay and equal treatment. ILO Convention 100 is also an equal remuneration convention. But these things for health workers, they are there already in international law. Similarly with workplace safety, 11F says the right to protection of health and to safety in working conditions, including the safeguarding the function of reproduction. I mean, I'm assuming that we could expand reproduction to be women's reproductive health or reproductive, a more generalized context. Women, CEDAW Article 6 calls on the states to protect women against all forms of violence and sexual exploitation. The CEDAW committee has general recommendations. So it's one number 19 on violence against women, and it's one number 24 on health. There's also one from 1993, Declaration on the Elimination of Violence Against Women, and regional conventions. But these instruments are here. They are enormously controversial today in the current political climate. But we do have a formal basis that will allow us to specifically foreground the challenges facing women healthcare workers. So my my input would be, we frame this not as bad luck or problems, but as illegal. This is already illegal, and it's a violation of already existing human rights obligations. And I think the more specific we can be about the law, the more specific we can be about the violation, and the more specific we can be about how this is gender specific, I think the more helpful law can be to provide a platform in the struggle to negotiate this social contract. Thank you.
Thank you so much, Kristin. This sort of help us to frame it all, also in terms of regulations and law, which is very helpful. What we'll do now, we have 10 minutes left of our time. And we have an interesting question here from Donna Gashi. And I'll read it to you. And while I'm reading it, it's a little bit, some lines here. You can reflect a little bit, you panelists, on how you will respond to this from your different point of departures. Donna says, as a trained social worker currently enrolled in an MA program in international health and welfare, where more than half of the students are women, I'm noticing that the majority of the professors, external lecturers, and the literature we read is composed by men. I cannot see any women on the stage, and so cannot see what my place will be after I graduate, what roles that are available for me. Knowing that women all over the world still are paid less than men, that especially minority women in Western countries are often overqualified and underappreciated in the healthcare sector. Am I, as a minority woman, by enrolling in higher education, contributing to keep this unfair system intact? Am I effectively supporting an unfair system? What are my options and what power do I have for creating a more equal world now as a student? And if I may I start with you, Ropa? What are your immediate reflections you want to share to this comment?
Yes, hi, Anna. And I want to say, that's a really great question. And it's too unfortunate that this is a reality in too many of the fields where women are well represented. We still see that there is the glass escalator where men are, in leadership roles. And I think, again, it goes back to the point of how can we use collective action? I really liked the points my co-panelists said, but also what, Christine said, that this is not just about us looking at, problems and thinking about, what are the solutions, but it is actually a violation of the contract that we've created socially. We have agreed to have gender equal societies. We've agreed to eliminate discrimination. And every time, women are not represented in equal numbers in decision-making and leadership roles, it is a violation of that social contract. And what we can do is really use the collective action, which Women in Global Health does give all of you a platform, you as a community connecting with as a Norway chapter. We can use that, voice together to raise these issues. Some really great examples of where we've already done this together with all of our chapters and globally is when the Universal Health Declaration on political declaration was being negotiated at the UN in September 2019, the very first drafts actually had no mention of gender equality, no mention of women's role in the health workforce. It actually took active mobilization on women in global health. We were the first organization to call this out, other partners, other big coalitions of women's feminist organizations together. And now that 80 plus countries that have all come to the Universal Health Declaration actually has the strongest language in health that is gender mainstreamed around women's role in the health workforce and women's leadership, in addition to sexually reproductive health and rights. So that's one example of how collectively we are much more powerful. And there are examples
why collective action is also part of the International Labor Organization's decent work agenda that has been around for over 100 years. And this is that all of us have said, this is a human rights issue. We all should do it, and how we can, make this a reality in all of the countries around the world. And this is ILO Convention 190 with violence and only formal work roles, but also informal work roles. And that's currently going through ratification. It was released in 2019, still needs to be ratified by governments around the world. And that particularly outlines the health sector as one of the top sectors where there's a lot of violence and harassment. So I think we do have a role and responsibility to use these global conventions, but then contextualize them in our day-to-day realities. And I would say to that person that is in that social work training, think about how you can use the Women in Global Health platform to bring dialogues locally, to engage with your university, to think about what are they doing to recruit women faculty, what are the other associations that are related to social workers, how are they approaching gender equality. So, again, use the resource and many of our partners, but think about how you form the system. We're here to fix systems, not women.
Thank you, Ropa. That was a rich reply and encouragement. Amanda, would you have a short comment to add? Because we are very soon now, we are wrapping up this session.
Yeah, I mean, from my side, maybe taking my nurse role more practical is, I think we have to create better pathways for nurses and women to go into leadership and management. As someone who's in leadership and management, it's not always very fun. I miss working with patients. I miss being on the wards with the camaraderie. And I had a Zoom date with my nursing colleagues. There's a real camaraderie within nursing in particular. The nurses I graduated with 24 years ago, we had drinks on the weekend, and they're all still on the wards, and they make fun of me for, am I really a nurse still? I haven't touched a patient in a few years. So I think in part of it's making sure that we encourage and identify those roles in leadership as a real pathway, and that they do add value. Because it's not always necessarily the most inviting of paths as well. And so I think, really encouraging female healthcare workers, in particular nurses, to learn those management skills and to think about the change that they can make, and make those positions exciting and a worthwhile career choice.
Thank you. I'm sure, Kristin, that we can tune in with what has been said now. And it's time to wrap up. I'd like to thank the presenters for invaluable contributions, also for sparking discussion. I think now is the point where we really could have gone on, and for making us reflect and continue to make efforts in our daily work. To me, and I'm sure for our audience as well, you have truly been inspirational. I'm proud and happy to feel this atmosphere among us, an atmosphere of solidarity and passion for health for all. Distribution of health is also about distribution of power, power in general, and then there is gender. The gender lens is always relevant, and when we speak healthcare, it is paramount. Thank you so much to all, and I hereby close this session and hand over back to Candela.
Thank you so much, Anna. Thank you to all the panel, to all the speakers. That was a really fascinating session, and I learned so much about the need for data and about framing this as a legal debate as well. We are now going to move on to session 4, and I'll hand over to my colleague Eva Turk to lead that session.
Thank you, Candela. So welcome to the last session of the conference. So bear with us for another hour or so. I promise we will give you some really, really good stories from experts in the global health field. Throughout the conference, we have heard basically with regard to the gender gaps and inequalities that we are facing in the field of global health. And the title of the last session is Broken Rungs and Glass Ceilings, Challenges, and I will, challenges for women in global health careers. But I will add here that this is also the opportunities for women in global health careers. So I just wanted to set the scene a little bit with regard to the broken rungs and glass ceilings, that we all know about the glass ceiling, that invisible barrier that is keeping women from making it into top management positions. But the broken rung actually starts a lot earlier. So the broken rung refers to the obstacles keeping women from advancement right at the start of our careers. And the biggest obstacle women face on the path to senior leadership is at the first step actually to becoming a manager. So I'm very, very excited today that we're going to hear from senior managers as well as colleagues from at the beginning of their careers. But I think it's also important because a lot of us work in academia, and we have been discussing that how COVID has also affected health professionals, also researchers, that we are actually publishing less than our male colleagues. But this is not affected only because of COVID. Actually, last year, a Lancet article has been published that looked at the academics in top schools, basically of public health. And what they saw is that there's a clear gender and ethnic disparities remain at the most senior academic positions. And this is despite the numerous diversity policies and action plans reported. In all universities, representation of women declined between middle and senior academic levels, despite women outnumbering men at the junior level. So also the ethnic minority women might have a magnified disadvantage because ethnic minority academics constitute a small proportion of junior level positions. And I think without any further ado, I would like to introduce the panel who will actually talk today about what are the tools to fix these broken rungs and break the glass ceilings. So I'll introduce to you first, I'll introduce everybody together and then we will have the panel discussion, so bear with me a little bit longer. Our first panelist is Dr. Akudo Anyanwu, who is an award-winning global health expert, public health innovator, and a social entrepreneur with 17 years of experience in the field of international development. Currently, she's a vice president at Texas Biomedical Research Institute, and before this function, she was the associate dean at Johns Hopkins University. Akudo, you are also the founder of Friends Africa, which is a Pan-African organization that fights AIDS, tuberculosis, and malaria by mobilizing businesses, governments, and NGOs. You are serving on many boards, and I would also like to say that basically you have received a lot of awards. I guess the years from 2012 and up to now have been really, really good for you. So you have received a Tufts University Distinguished Service Award, a Harvard School of Public Health Innovator of the Year Award, an Entrepreneur of the Year Award, and the Social Leader of the Year. Akudo holds an MD in Medicine and Master in Public Health from Harvard University and a bachelor's in molecular biology. Then we go to Dr. Anna Staudal, who all of you have met already throughout the conference today. And I don't think you need another introduction, but I'm very happy to hear from your side with regard to the president-elect and your path as a clinician throughout your career in global health. Then with us is Jennifer Gilbertson, who is currently the coordinator for humanitarian innovation at the Red Cross. She holds a master's in bioengineering and innovation and design. And Jennifer, you came to Red Cross from the private sector, so where you were working at the Lerda Global Health. I understand you're passionate about creative problem solving and inclusive collaboration to address gaps and inequalities in global health. You have a multidisciplinary experience in global health, product and program development, implementation, scaling, human-centered design and strategy, and biomedical engineering. We are still waiting for Dr. Noor Khan. So when Noor joins, maybe I can introduce her then later. And if not, then we will have more time for our panel now. So with this, Akudo, maybe you would like to start with your journey throughout the global health. Thank you.
Thank you, Eva, and good morning from Baltimore, where I currently am. It's great to see all the panelists, all the amazing panelists you've assembled here, and thank you for putting this together. So as Eva mentioned, I have a background that spans several years in the field of global health. That journey is one that was really formed in the heat of the HIV/AIDS movement for Africa, which was really around the turn of the millennium. The HIV/AIDS movement was quite strong and sort of heated up in the 80s and 90s in the US. And then we saw what the epidemic and pandemic did in Africa as it took roots there and was devastating for communities and for families and nations across Africa. And so that was at the time when I was in my training in both medicine and public health. It was really shortly after that training that I was able to take a role at Columbia University, where I was very fortunate to be mentored by some giants really in public health. Two gentlemen, one was Jeffrey Sachs, who used to head up the Earth Institute at Columbia. And the second person is now late. His name is Alan Rosenfield, and he was the Dean of the School of Public Health at Columbia. So I was mentored by them, and that's really how my journey began. And they were at the time setting up the mechanisms in countries to receive funding from the Global Fund for AIDS, TB, and Malaria, as well as setting up the Global Fund itself. So I got to be immersed in that process of advocacy, process of policy setting, governance at the country level, program management, proposal development. It was really a trial by fire. I was sent to work in Rwanda and then Nigeria, working with stakeholders at the country level to agree on priorities and then develop proposals against those priorities, and then set monitoring and evaluation parameters around grants, and then program monitoring and program execution. So it was a blessing really to get that deeply involved in such an amazing movement around both all three, AIDS, TB, and malaria. And that led to, obviously with all the funding that was available and the expertise, we've seen a lot of great results in those three diseases. I also served on the board of Rollback Malaria for 4 years, representing NGOs at the table, at the seat of the table. So that, it's just kind of a cross-section of the early part of my career. I went on to, after spending about 5 years in the trenches, as I just described, I moved on to what was called global health advocacy, working with the same Global Fund for AIDS, TB, and malaria, but in a different capacity. So for 7 years, I then went into this role of mobilizing African stakeholders, government, civil society, private sector, in support of AIDS, TB, and malaria programs across Africa. And that then took me to different parts of the world as a spokesperson for these issues, including holding meetings with the former Prime Minister of Japan, Mori, to convince him and his government to give the Global Fund $180 million, and this was in 2008. So I have a lot of interesting stories working with stakeholders across the world in the area of advocacy for global health, but also policy work, program oversight and evaluation, and lots of interesting experiences. I've also worked for Emory University in the area of neglected tropical diseases, and carried out I led a coalition on neglected tropical diseases, specifically soil transmitted helminths. And following that, I took on the associate dean role at Hopkins. And as you know, Eva, I have just recently began the role at Texas Biomed. Texas Biomed is one of America's foremost research and oldest research institutes on infectious diseases. And what we're doing is we're working on tuberculosis, working on COVID-19, and a whole array of infectious diseases, creating prevention techniques, vaccines, but also the therapeutics for these diseases, and bringing really cutting edge research to the world as a foremost global health institute. And so I look forward to speaking more about that. The story, though, I think is what you're trying to get at, Eva, and that's an important part, I think, of all of our journeys. You know, that is the professional story, but there's always a personal story that goes with this. And for me, I found that I was always the only person in the room who looked like me all along the way. And so it required my being confident in myself, my being bold, my growing to sort of appreciate the interventions and comments and contributions that I had, and just understanding and believing that they were valuable. And for me, this is really rooted, everybody has a story, but for me, it's rooted in my late father, who was an academician, an activist. He was a professor of political science. And really, he taught me that my voice mattered, and his voice really mattered. We were raised in a home that was very much focused on serving the community. And so I saw that growing up. I knew that that was important. And I think it was that foundation that gave me the strength to stand strong in the midst of people who didn't look like me, who were perhaps not used to having me around them. And I think that we all benefit from diversity. So I think that's one challenge with sort of breaking the rungs, as you mentioned, is being able to be strong in a place where you may not look like anybody else in the room. I think the other part to this story is having kids. I have 3 kids, and I've taken them all over the world and have done all of this work, still knowing that I can do it despite having kids. And sometimes you're the only one with kids, and sometimes other people have kids, but they don't, they don't really see it the same way. I think my point to everyone is that it's okay to be a mother, to be a person of color, to be a woman at the table, and your voice matters. And I learned along the way that my voice mattered. It took me a while to get there, but my message to you is that on day one, accept that your voice matters, and that you ought to be at the table, and take a seat firmly at the table and represent the issues and the people who look like you, because that is a valuable piece to the equation. And if no one is at the table who looks like you, then who will bring that story forward? So I'll stop there, and thank you so much for setting up a very important discussion. I look forward to hearing what everybody else has to say.
Thank you so much, Akudo. Yes, I think this is also part of my question with regard, how can we then change the narrative around you know, having a seat at the table. And I really like when you say, like, just take the seat at the table, I think, and this start from the start, yeah, and not wait that the seat is offered to you. So thank you so much for this. And then I'll give the word to Anna. So please share your story, your journey, and your tools to fix the broken rungs and the glass ceilings. Thank you.
Yeah, I have to tell the audience also that I was invited to do this just before the session. I'm very happy to speak on these matters. The risk is that I have so many reflections, so I don't manage to filter them and in the order I want to, and in a way that can make them interesting to you. But well, I started at medical school in 1981. And at that time, part of 30% female of the student body, we were 30% female. Now it's more or less the other way around. And I have been working clinically all since I graduated in the same place, more or less, in the center of Oslo. During these years, Norway and the Norwegian welfare state has developed into one of the most equal, gender equal societies maybe in the world. So very lucky to be part of that and to grow and develop in that society. But I'm tempted to ask if that's the whole story. I mean, has this impacted my work as a clinician, as a female clinician, and the clinical work the way it should? Are we asking, has it influenced research, professional development, the way we make decisions, the way we diagnose? And you will not be surprised if I say, no, I don't think it has impacted the content of what we're doing. And that has been a frustration to me, and is of course also related to how I have perceived myself as a female clinician over these years. I can give you a few examples. We know from social psychology that men and women are perceived very differently. I mean, soft skills are taken as an of course when it comes to women, whereas when men provide these skills, back channeling, empathetic listening, things like that, it's an asset. Whereas if a woman provides the same skills, it's taken as an of course. So we start at different levels, so to say, in our relationships with patients. This is also positive expectations, is of course also a positive thing. I could have elaborated more on this, but this is one point I will make. It also influences, and recent research shows that male and female general practitioners make decisions, I mean, given the same clinical problem, they land on different conclusions. Also when it comes to, for example, issuing sick leave certificates, saying no to expectations or demands, things like that. And if you are decisive, and we have to, I mean, being a clinician, and not least in family medicine or general practice, we are filtering, and we are providing triage, screening. You have to make decisions, and you have to live with uncertainty. Female doctors are more likely to be sanctioned when we are decisive. So that's just an example. So to my pathway in the political, on the political arena, and the organized family medicine, so to say. I was the second president or chair of the Norwegian College, female president of the Norwegian College of General Practice. the college at that time was 20 years old. I moved on to the Nordic level, where I was the first president ever, because I was the co-founder of this federation and a woman. Then to the European level in my organization, Wonka Europe. I was the first female president elected in 2016. Again, in an organization 25 years old at that point, which tells a lot about the organized crime, so to say, the organized family medicine. And now the second female president to be in Wonka World, an organization of 50 years. So it goes without saying that gender is an issue and has been an issue. What have been my tools? I think, Akudo, I can identify with some of the elements in your personal history, because I was also raised to be self-confident and in a slightly unconventional family, which I think helped me. But again, I mean, to break if there were glass ceilings, but also it was not a hindrance, but I was never seeking, I mean, the core of my own group, which were the Old Bodies Network, right? So, and that was not because I didn't want to, but I didn't find it, I mean, that was not, they were not that interesting. So I often took unconventional or controversial standpoints in discussions. And looking back, I questioned some of the courses without understanding that that was what I was doing. And I didn't realize that when I was met with skepticism and negativism, etc., then that was also gendered, and of course it was. So it wasn't a tool because it wasn't deliberate, so to say, what I did. It was a result of who I was raised to be. That said, tools, if I should say a few words or give advice, as I sometimes do when younger people seek my advice on the international arena, and that goes for all genders. I mean, team up with a few. You don't need the majority, but team up with a few and build trust. That is absolutely paramount. Also to stand the pressure, because when the going gets tough, it is often gendered. And of course, I've had my period of time with small children and all parents in need of care. But he should have listened now. My husband will soon be here with me. Our relationship has been absolutely, I mean, the cornerstone of being able to do what I have been doing and challenging the glass ceilings, because I've had the support in my own family and with my own husband. So team up and ask the uncomfortable questions. That would be my, if I should give two advices or two rules, at least, I try to follow myself. And it doesn't have to be the big communities of people you have to agree with, but have a few. And also link up with networks like Women in Global Health. Thank you. You're muted.
Thank you, and thank you so much for your flexibility in the first place. And I was just thinking, maybe I can add, because I got a very similar advice also from a colleague when I was younger, and I was asking, it's conferences, and sometimes I don't dare to speak up when I have a question, and it's, you're thinking about this question, you miss half of the talk because you want to get into the question. And she said, Eva, you just need to get sit in the back in the auditorium, prepare your question, and then raise your hand, and then everybody will turn back to you and see you. And this is how you're gonna get noted. And for me, this was some of the things that it is a tool, basically, to, of course, you have to have a smart question, yeah, but it is something to also like pump us up a little bit as a very small thing. So thank you so much for this. We're gonna talk more in the discussion, and please put questions in the chat for the panelists, and we can discuss this later on. Jennifer, now we're coming to you. You are representing a little bit of a more younger population, or the junior population here in the panel, and what we were discussing, that you can bring actually your perspective to potential, your expectations. You are also working in the Red Cross now, where we know that the hierarchy in the line management is quite a strong aspect, but you also bring your background with the innovation and the human-centered design. So I think it would be very interesting to see from your perspective to see what can be done, how can we change the narrative, and what do you see as opportunities for your colleagues in this?
Great, thank you so much, Eva. And as I guess the second to last speaker on the last day of the conference, and there's been a lot of really interesting points already made that I could tell about my story that would just be repetitive. So I think as you're suggesting, Eva, I'd really like to focus a little bit on two things. Looking a little bit about how women start to make movement in organizations that feel a bit more traditional, but also maybe reflecting as somebody who is younger on how the field of global health is also changing, and how maybe there's space to enter in different avenues. Because if you were actually to look at my resume, you would be a bit surprised that I am where I am today. And I think as Eva was saying as introduction, I completed my undergraduate studies with a dual degree in chemistry and French. And during that time, I was rotating through a variety of research, from virology to nanomaterials. And then I went and I got a master's degree in biomedical engineering with a focus on product development and innovation. And I think it's worth focusing on this a bit, because my journey should be an example that, there's not necessarily a correct path going into global health. And just a quick note about being a woman in STEM and medtech is that, I was told that when it comes to getting venture funding, teams and companies with women simply did worse. Like, women just can't get funding. And this information was obviously quite disheartening to me, because it was shared as a fact instead of something we should be standing up against and fighting. Because at this point, I was surrounded mostly by men in a program run mostly by men, with clinical and technical advisors and teachers who were mostly men, and which is why representation is so important. And we've been hearing this throughout the day. So anyway, after my studies, I joined a nonprofit company in Norway focused on maternal newborn health. And when I first joined this maternal newborn health space, my reaction was definitely imposter syndrome. I felt surrounded by clinicians and colleagues with public health, and thought, who let the scientist or engineer into this room? Because that's what you see when you look at my degrees. And what it took me a while to realize is you don't have to have the same story as everyone else. And some of the best advice I received from a mentor when I was telling her I was thinking about going back to school for for an MPH was, don't lose what makes you special. You know, take those unique parts and own them. So I ended up not getting that MPH, and I spent 5.5 years at this nonprofit company, and during that time, I tried out a variety of roles, and some of these roles resulted in a change of job title, and some of them didn't. But you know, opportunity, it's a really special thing because it opens doors which you don't know existed. So at different periods, I was our go-to person on neonatal health, family planning, safe abortion, adult learning and simulation, environmental and economic sustainability, supply and logistics, reprocessing and materials, business strategy, a whole variety of topics that I didn't necessarily have ownership of a few years of earlier. And I think one thing that really made this possible and to kind of try these new things on and to grow was that I had strong female role models in this organization. And my managers saw my love for learning and they created that space. And I also, as I took on this responsibility, I also decided to formally or informally at times mentor other women in my team. So sometimes this meant weekly check-in meetings to help debrief certain experiences, discuss and plan the week ahead, or just act as a sounding board. But quite often it also meant sharing my own experiences in negotiations. It meant being transparent about my salary. And through creating these forums for sharing and discussing challenges and ideas, I actually saw a lot of grassroots change happening in the organization. For example, we just discussed these topics like sexual harassment policies or how to bring up, strategies for bringing up different topics with our leaders. And I actually, I saw changes. For example, it was a pair of us who started a petition for meatless Mondays in the organization that got implemented. It was a pair of us who got a meeting room changed into a room for breast milk pumping. So, I just want to make the point that is having female voices at the top important? Absolutely. But it's also really powerful when women start initiatives from the ground up. And so, as Eva was saying, at the beginning of this year, I transitioned into the humanitarian sector, and I knew this was going to be different from the private sector. And just to say that I don't feel like I've been in the sector long enough to make huge generalizations, but I actually have already seen similar interesting grassroots initiatives being taken on by women in the organization. And one thing in particular, one really interesting story, is that I've been seeing that women in non-leadership positions have been consistently calling out leaders when there is not equal or adequate female representation at events. And to be clear, the lack of female representation has not been intentional, but by creating awareness around it, it shows that we need to be intentional about including women and other marginalized voices. And I have to say, I already see change. Leaders have openly recognized and apologized for events where women didn't have an equal presence, and they have been measuring the percentage of women in leadership positions and sharing that. And so in the international department where I work, women make up about 50% of leaders, which is quite good compared to many other organizations in the social sector. But we also need to be aware that female leaders have an equal speaking space. We also need to make sure that the leadership roles that women have are not only ones that are seen as traditionally female. I'm American, so examples I think of are women need to not just be the Secretary of Education, but we need women as the Secretary of Defense. We need fewer first ladies, and we need more Madame Presidents. Because in the humanitarian sector, in the work we're doing, women are often even more vulnerable than men. So, we need to make sure that female voices are there to shape and deliver the aid. And just to say that today, is it surprising that an event that's been organized and run by women has a variety of speakers from different backgrounds, industries, and experience? Because, I think this is the beauty of global health, and this is the beauty of women coming together, that, we're not, I think I really want to make the point that, we can't work in silos and traditional structures and think that we can meet the Sustainable Development Goals. And if we need to solve today's problems, we can't have just traditional people working in the same way. We need to bring together intersectional roles to solve these problems together. And just this last point being that the position that I have right now in the Red Cross, it didn't exist 5 years ago. I also have female colleagues working on digital transformation, on data visualization. And I'm sure if you find me in another 10 years, I'll be working on maybe something that doesn't exist yet. Maybe it's the intersection of blockchain and epidemiology, or virtual reality and behavior design. And, you know, I just want to make the point that you just have to be open to the new opportunities coming your way. And you have to just see where your passions take you. So anyway, thank you, Eva. Back to you.
Thank you, Jennifer. Yeah, I can definitely relate to a lot of things that you are saying. My issue was also, you know, I have a business background, and I felt very similar. And the suggestion I got is like, why do you try to fit in if you can stand out? So very similar to what you heard. And I think with regard to this, also the younger generation being more of the multi-potentialites, yeah, as we like to be called. So it's also with regard to going away from these silos. I think it's very, very important. So thank you for your contribution, Jennifer. And then just before we go into the discussion, I would like to introduce Dr. Noor Khan, who joined us a little bit later. Noor is a senior Norwegian, let me just introduce you, Norwegian career diplomat and practicing medical doctor. You worked clinically at the University Hospital in Oslo, as well as the Clinton Foundation in New York, and with the WHO in Geneva before joining the Ministry of Foreign Affairs back in 2008. And in addition to your medical training, you have a master's from London School of Economics and London School of Hygiene in Tropical Medicine in Public Health. So recently, then you returned to ministry in Oslo after serving at the Norwegian Representative Office in Jerusalem, where you were responsible for the UN portfolio, humanitarian and health issues. And currently your particular focus is on developing global health policy at the ministry. So we are very happy to have you with us, Noor. As said, we are discussing broken rungs and glass ceilings. So please share your story with us, and also with regard then to from your governmental perspective a little bit, and then we can pull everything together in the panel. And I see already questions coming in. So please, I will read the questions later on. Thank you, Noor.
Thank you, Eva, and thank you for inviting me to talk a little bit about my experiences, both professionally and personally. And I'm just really in awe of all my fellow panelists, of their journey to and in public health. I think a lot of this has got to do with both serendipity and also just by having kind of a goal, but not really sure what the goal is. For my own case, once I graduated from medical school in 2002, public health was kind of not my, I hadn't really envisioned my career in public health. And when I did, I thought perhaps having a degree, a medical degree, would be kind of a step into public health without having an official master's. But I think it was a lot of my fellow colleagues in public health that emphasized the need to kind of bridge the clinical world with the public world, with having a master's in public health, in international health, for my sake. And I think that was my first introduction in public health, basically just the student body, both at LSE and LSHTM, which was fairly equal distribution of male and female. So that was very encouraging, and didn't really give me an impression that it was more male dominated before later, I would actually say. But the student body within public health was, from my experience, quite 50-50 when it comes to gender. I joined the diplomatic track, the Minister of Foreign Affairs, which is perhaps not the natural course of a public health degree. Norway obviously is very large in public health. We have had a lot of, for the last 20, 30 years, we have been very heavily invested in global health, if it's maternal child health or the immunization programs through the Vaccine Alliance and also through CEPI and SRHR. So it's been a lot of focus for the last 20 years in public health from the Minister of Foreign Affairs. And however, joining the diplomatic track is not really where you would envision yourself having a public health degree, but through my background and also my curiosity on following kind of a public health sub-track really within the diplomatic track, I've been fortunate enough to work in the field of public health for the last 15 years in different capacities, both stationed abroad but also stationed at the ministry. I think there are, when we're talking about glass ceilings, my experience is that one has a lot, one can gain a lot of having a mentor, and especially a female mentor who can kind of guide you along. I found a few. I can't say that I've been exposed to very many, but I think you kind of need that one person who can take you they can take you under their wings and in a way push you in the right direction and expose you to the right network. And I think that can, in a lot of ways, encourage and push you in the right direction, because but again, you kind of have to know where you want to go yourself, more than it is. Sorry, I've got 3 kids at home and I'm just hearing a lot of screaming now. So if I have to run, just I'm sorry for that. But yes, I think having female mentors is definitely something which helps, which can help us all. But on the way of finding tools, I haven't really discovered them for myself, except for really trying to network and finding that one person who gives you some space and information and guide you really. But it is surprising to also that once you do come on a senior level, you are met by very male dominance. And I can also relate to a lot of the panelists have been saying about finding your inner voice, and often men have this ability to convey their messages, and then you become a bit quiet because you could have said the same thing, yet you didn't go first out. So a lot of that kind of is trying to find your voice, and you always bring something new. You always bring your own story to the table, and nobody can really have the same information as you can convey. So I think it's just also about trying to get that self-esteem enough to believe that you're important and you have a voice, and that you are bringing some form of new direction to the conversation and to the topic. I'll leave it there.
Thank you so much, Noor. I think this resonates with everybody and what we have already heard. And my question then to, I guess, all of you, we have heard a little bit of this, but how do you personally empower your younger colleagues? What are your tools to then help them going on the ladder? Maybe Akudo, we can start with you. And I was thinking maybe this could be also a way. I know that you are the architect behind the Conference for Women and Girls in Africa Summit. So I think this is also part of the things that you do with regard to empowering the younger ones. So maybe we can start with you.
Thank you, Eva. That's great. And even, yes, we are collaborating, and in addition to a number of other amazing women around the world, to pull together women and girls across Africa and to empower them. So definitely take a look at what we're doing. Go to wags2020.org and take a look. It's a group of women who are hoping to lift the voices of other women around the world. So in terms of empowering, I think as a manager, you know, with each of us, right, in leadership positions, we're being watched by younger people. And so whether you're a director or a manager, or you're leading a department or a unit or whatever it is, there's an opportunity there to be a role model, whether we like it or not, because people are watching our leadership styles. So that's one part, which is by osmosis. What do we do when we walk into the room? And for me, I've been pretty deliberate over the years as my leadership style has evolved. I've been pretty deliberate about my position in the room vis-a-vis everyone else. And my position is one that aims to, hopes to allow others to exist freely, to speak freely, to be empowered, to know that their voices matter. And so I'm pretty upfront with any team that I lead in letting them know that creating that culture of openness, transparency, where people feel empowered is important to me, and that I appreciate and trust them and believe in their voices being heard, and believe in being a vehicle for their recognition and upholding their dignity. I mean, that applies to both men and women, but I think women particularly feel that may be at risk for them. And on top of that, I would add that women of color feel that they're even more at risk of not having their dignity, their voice heard, being recognized, being trusted, being given the benefit of the doubt. So I think it's all of these aspects that we allow as leaders to happen in the space that we operate in. So for me, it's very important that people know that I believe that giving people the benefit of the doubt, trusting them, appreciating them, having their voice come through, and recognizing them and upholding their dignity is an important part of what I do as their leader or mentor or manager. I also believe that people's personal experiences need to be heard so that they don't show up at the workplace as just a project manager or a number, that they come along as their full person. So I'm very conversational about people's families and children. And I have very open conversations in the workplace. So as to normalize people's lives, which are indeed normal, but we kind of have a way of making it abnormal to have children, making it abnormal to breastfeed, making it abnormal to be a human being. So normalizing all of that is something that I think through my challenges and pains in breaking the ceiling and doing this without seeing people who looked like me, that then crystallized this as a value to allow other people to feel and be normal and be themselves in their places of work.
Thank you, Akudo. Anna?
Yeah, here's my second time. I hope that I am a leader the way you described it now, Akudo. The leadership style, and what I hear is, first of all, a collaborative leader style. So and including everyone. And that is not only about gender, but if I should again focus on gender and looking at my young female colleagues and how to help them and support them. One thing is to open the doors, to invite them to committees and groups, of course. There's another issue. I thought about it after the first round in this panel. When you climb the ladder in a male-dominated area, you get more visible. And one thing is what comes under the umbrella of Me Too activities. That is one thing, but there are more subtle mechanisms which are not so easy to detect and realize if you don't have people who have walked before you and recognize the mechanisms. And that is, let me give you an example. If you like to dance and you like to be partying, I mean, that is very good. It's good to party for many of us, to laugh, to flirt, all these things. To see how that can be used against you, even if nothing wrong, if you get me, happens. This is something, and now I'm personal. This is from my personal experience. And to help younger women see, support them, okay, go ahead. I like your style, but beware. This can, not to warn them off, but prepare them a little bit for reactions which come suddenly. The reactions are there in different situations, and it fires back, and you don't realize before some time has passed. So I think to be the eyes and to help also younger women see and realize these mechanisms. That is actually something I'm doing quite actively, because I'm also encouraging women to play out. I mean, have a good time. What I've been doing in organizational life is voluntary, it's unpaid. And I mean, we spend a lot of time and effort on the work we're doing. So of course we also shall have fun, and we shouldn't, being a woman shouldn't prevent us from also having fun together with men. So that is one point which is really a matter of the heart for me.
Ava, can I build on what Anna just said, just really quickly? Just to say that, thanks for sharing that. I would add to that I think as women, we can be, as we watch out for other younger women, because I found myself in a position where I'm watching out for women who, it's a little bit different. This is women who don't know that they're being bullied on the job in some aspect. And we can be the eyes for them to say, what you're experiencing is not good. It's not normal. So let's not normalize that. Let's address that. Or the way you're feeling is valid. If you felt that you were cut off, or you feel like you're being watched, or, I've had women share these things with me, and I've had to explain to them that, that's not a normal way to be. And here is a way to reduce this experience or address this experience. Because a lot of women, go through, and sometimes, let's also be frank, a lot of women will experience this kind of, we call this microaggressions. They will experience it from other women, right? Who believe that it's a food chain, and that there's this, it's a severe hierarchy, and you've got to eat the next person, the other person eats you. I mean, let's face that reality, that women do impose such behaviors on one another. And I have a zero tolerance for that in the teams that I run. So a big part of that is listening in to the people who not just report to you, but the people who report to them, to make sure that no one's kissing up to you and kicking down to others. These are all things that women endure in the workplace, that they have to be supported and guided to be liberated from.
Yes, and yes. Well, I wanted to say that it's actually, with regard to this, it was the Margaret Thatcher favorite quote. Yeah, there's a special place in hell for women who didn't help other women, and I think that's in a sense where we all come in to lift ourselves up. So Jennifer, we have heard a bit of your story already, how you have started, and I think that's very, very inspiring. And I think with all of this grassroots issues and opportunities basically coming across the different organizations, how do you personally then do different things to empower your colleagues?
Yeah, and maybe just to make one other quick point is also in forums such as these, or other maybe global forums, the importance of non-traditional voices. And I think one of those is the voice of the young woman. And I see it, I mean, yes, I've been included here, but in my career, I'm not even really that young. compared to some of the women that I have worked with. There's a lot of, just to say that there's a lot of amazing voices happening for those who are even still in their studies, who are doing amazing grassroots movements. And we have to make sure we legitimize what they do, and by giving them a voice and giving them a platform. And I've been seeing this happening more and more at global health conferences. I think a really great example of this is the Women Deliver, where they are intentionally not having the traditional voices who represent global health sitting on panels. So just to kind of say that we have to be conscious about creating these spaces. But to get more directly to your question, Eva, I think a lot of this is about building trust and creating these safe spaces with other women, so that you can have these open conversations, because unfortunately official forums like this do not always exist, and so these are definitely things that happen a little bit on the side. But I think as well, I mean, one of the best managers I've ever had, something she said to me is, you look good when you make your team, when your team shines, you shine. And I think if we can remember that for those of us in leadership positions, that if we give opportunities to women who are lower, and we show how much we can make them grow, it reflects really well on how we are helping foster our team as a leader, and it shows our own confidence in our positions as well.
Yeah, thank you, Jennifer. And Noor, you spoke a lot about networking, so I'll just bring in a question also from the audience with regard to basically then your empowerment personally, but also, do you have any tips on how to network during this COVID-19 times? I feel like it is harder to network because you meet a lot less people, or have less moments to informally talk to someone after the meeting, so it is an issue with regard of not being able to have face-to-face meetings, and what would you then suggest to do in that sense?
Definitely, there is obviously a limitation on how social you can be these days, but I think we all read the same literature. We all kind of are exposed to the different public events, and I think sometimes when one hears a voice, it just resonates a lot with your own. And just trying to send an email to people, like, it doesn't have to be several people, but just sometimes you find somebody who is kind of who speaks the same language as you do, and I think just reaching out to a lot of people, to that particular person who you aspire to be, and I think it's just, women generally do encourage each other and really obviously want to help one another, and I think just reaching out and just showing your vulnerability and your want and desire to be included and seen. I think generally, whenever I've done that to fellow colleagues or female mentors, I've always been positively surprised on how helpful people really are, and really kind of surprised that they have been targeted as a possible mentor. So I think there is no shame to reach out and to show how vulnerable you are and how really in need of a mentor you are. So despite kind of the limitations on the physical access one has to different forums, I think Googling people, finding out about them and contacting them directly, and even just for a quick chat, if one needs to find out if one should go for a master's in public health nationally or internationally, or what kind of job you're looking for. I think there are so many women out there who are willing and positive to share their experiences. And so I think, yes, I would encourage people to reach out. And I think they'll be positively surprised over how much information and willingness there is to share of their experiences.
Yes, thank you. And I think it's also probably if somebody doesn't respond, we shouldn't take it personally. I think we often take things personally and then give up too quickly. So I think this is also part of being persistent. Probably is a way of moving up the ladder in a way. We have another question which is more on for the medical studies. So do you think that including gender equality related studies for medical students would help train doctors in understanding and being conscious of the impact of gender equality in health? I think, Anna, you are very involved in this, so maybe you can start.
Yeah, I can only say yes. I don't think it's not only helpful, but it's necessary, because distribution of disease and ill health is gendered. I mean, all perspectives, always, and also to support, because the workforce also in the Western world, that has been the case in many other places in the world, but in the Western world now, the medical workforce is, the majority is women. So women, physicians and nurses, all health professionals also need empowerment and to understand how gender plays out in the consultation, in the encounter with the patient and groups of patients. But not least, and there are many examples how, and that can be in favor or the opposite of different genders, but also as we are moving along now and having a broader spectrum of gender, it is absolutely paramount to serve people and our populations to understand the phenomenon of gender in medicine.
Yes, thank you. Would anybody else want to add anything on this?
I would like to add to that, and just to support what Anna said, I agree as well. You know, back in the days when I was a medical student, I remember we used to learn about the patient, doctor, and society, and we used to learn about how, you know, the focus actually was very different. You know, it was very much about almost how to blunt yourself as a physician and focus fully on the patient. Things have changed now. I think, you know, physicians are being asked to be human beings, which is better because I think you can be more authentic. And so I marvel at the young medical students and how they're much more free to be themselves now. But I think in addition to that kind of change, we also need for there to be more training on gender, but also I think, you know, the varied nature of gender across cultures. I think there's a tendency for us to assume things about gender. So my background is African. My parents immigrated here to the US in the 60s. And I was born in Philadelphia and to a Nigerian home in the US. So I'm Nigerian American. And what that means is that the notion and the nuances that come with gender will be very different for a family like mine versus a family that perhaps doesn't have the African background. So we make a lot of assumptions about gender, I think, and so breaking it down and trying to ask the necessary questions to understand this a bit more is really important. I find that women of African descent in many ways are way behind the starting point when it comes to gender discussions. And so we might be talking about, well, how do we equate, you know, sort of achieve that career equality and get to gender equality, whereas, you know, women in Africa are not even anywhere near that yet. I mean, they're trying to be recognized as people with rights, you know, with people with rights to even own property. And so when we're having these conversations collectively, I think understanding the gaps as far as progress is important. That way we can help each other a bit more.
Yes, thank you. And I think with, you know, having this collective action actually starts with an individual. So we have 5 minutes left in the panel, and I have a question that actually I would like to ask each of you. and which is with regards to what advice would you give your younger self, basically when you started, you know, the studies, or when you graduated, or whenever you feel, and is there anything that you would have done differently? So Akudo, I have you on the screen already, so maybe you can start.
You know, it's funny. Somebody just asked me this question yesterday, so I'm going to give you the exact same answer. My advice to my younger self would be, stay on track. You're on the right path. Trust your gut. Be confident in who you are. It's going to be all right. Stay on the right track. You're doing the right things. Trust your judgment, and trust your gut feeling. It never disappoints you. That would be my advice. I think young women spend a lot of times questioning their decisions and their thoughts and their judgment and their gut feelings, which is the most.
Yeah, and I think this is what you mentioned, Jennifer, in your talk. Actually, you had this imposter syndrome. So what would you say then to your graduate self?
Oh gosh, just to agree absolutely with what Akudo is saying, that, you know, I think you're always, I think throughout all of our journeys, there's always stages of questioning all along the way. So it doesn't end. I think we can probably agree. But I think what I would say to myself and to a lot of the younger women who are here today is to be kind to yourself. You know, not everything is going to go how you plan. There will be good things that you didn't expect, but there will also be challenges and humbling moments. But don't let it put out the spark that is driving you in this field.
Yes, wow, the spark. Be true to your passion, right? In a way. Noor, maybe you can share your advice to your younger self.
I like Jennifer's comment about be kind to yourself. I don't know how many medical doctors there are out in the audience, but I think for me, it was very difficult to know whether I should leave clinical medicine and just venture out in public health. And so for me, I've kind of done both. I've kind of tried to keep up my clinical skills by working part-time at a clinic, just to kind of be able to do both things at the same time. And I guess what I'm trying to say is that no decision you make has to be so definite. So whether you choose a certain career path or a certain organization or a certain interest, it doesn't have to be 100%. You can do, one is so multifaceted that one can do different things at different times in life. So if you want to do something for 5-10 years, don't be scared to switch. Don't kind of put so much pressure on yourself that once you've chosen a path, you have to stick to that path. And I think that's the privilege of the younger generation, that you don't really have to be choosing the job where you're planning to retire. I think you have got the luxury of choosing different paths in one lifetime, whether that is going into business or clinical or public health. I think public health is such a huge umbrella, and there are so many paths under that. So just don't think everything is so definite and that you lock yourself into one thing, because you don't. There's always flexibility and room to change and try different paths.
Yes, thank you. And this is what Jennifer said before. Her job didn't exist a few years back at all. So there's so much opportunity. So Anna, just to finish off this really interesting panel, please share your advice to your younger self.
I'm very happy for the advice I already got from my sisters here. I would also say, you said, Akudo, to trust your gut. And I understand that is literally, not literally your gut, but also I would add, and your brains. Because you're most likely just as smart as the males taking the floor. This reflects the mechanisms between the genders. And in addition to that, I would remind myself that it is very, very valuable to have one or two good male friends, because you learn from different perspectives, and it can help you to develop your own gendered self as well.
So get your support, whatever it is, in the way, the support system. Thank you so much. I will give the floor now to Ingeborg and Rupa to give some closing remarks. I feel very, very privileged that I could facilitate this panel. For me, I learned a lot, and I really feel humbled to be in your audience. So thank you so much for taking the time and being with us.
Thank you, Eva. That was a very fascinating session. So hi everyone, I'm Ingeborg Hovitsen. I'm the leader of Women in Global Health Norway here in Oslo. So I just wanted to tell you a little bit about what we've been doing this year. We started out with 10 to 15 women in 2018, and today we actually have well over 300 members. So that's quite amazing. This year we have created a searchable booklet highlighting the broad diversity among women working in the field of global health in Norway. And we've seen quite a few interesting things during these 2 days as well. And this booklet can be really handy to form new collaborations, to find resource persons for courses and other engagements. So if you're interested in joining Women in Global Health Norway, do you want to be part of the booklet, please contact us. We're here and you have our web pages. So I also wanted to say how incredibly proud I am, having listened to all these great presentations and comments over the span of this conference. And my heartfelt thanks goes to the great team that has organized this with us. Our great appreciation goes to Candela Iglesias, whom you met today. She's the founder and director of Global Health Advisors. Eva, your moderator during the last session, senior researcher at UIO and associate professor at the University of Southeastern Norway. And Sarah Osman, whom some of you met 2 days ago, founder of Osman Advisory Services. And then in addition, few things would work as well as it does for me and my secretariat without my colleague Camila Rodriguez. So thank you so much. Now, I really want to just hand it over to Rupa, who will share some reflections before we close our conference. Thank you so much for being with us. I hope you enjoyed it as much as I did. Rupa, over to you.
Great. Thank you, Ingeborg. And just, it's so wonderful to have joined in both of the days and really learned so much from the rich discussions. I want to just echo the sentiment that the woman power is out there, and you are showing that as a community of women in global health in Norway. And I really want to congratulate you for taking these efforts to organize a list and bring visibility to women. There is work to be done in every environment, every context, and I think that it just shows the leadership of the team, but also the community that you have created. And some of the key reflections that I have from this summit is, clearly there's a strong message that we know that women are critical to the health system. They hold the health system up. They make up the health system. We've heard it in many, many different ways. And yet we have a lot more work to make sure that, women's leadership, which is there and women are leading at the front line, continues to be at the most influential areas. So we call on gender transformative leadership really to be our pathway. And for those that are been engaging these last 2 days, I really hope it's quite clear that we're not only talking about parity and representation, but we're really talking about shifting the paradigm and having a cultural shift in global health so that we truly have enabling environments for all genders to thrive. And this does mean looking at things from a gender lens, but as much with a power lens. And today I was able to join panelists who really talked at heart about, this is not just about, representation, but it's a human rights issue. And so I really do encourage all of you to not only think about this as your own individual struggle, but see that in solidarity, you have a community of women and allies from all different genders really supporting you in this realization of what the challenges are and how we can take the conversation from fixing women to fixing systems, and that you're not doing this alone. It is really collectively. I'm really delighted to say that we have over 24 chapters around the world that has doubled in just the past year. And please see yourself not only as a member of Women in Global Health Norway, but really as a member of a growing, vibrant global movement that is eager to engage with you, to connect with you, to work with you, and see that as a platform to really drive the social change that we need. And now is the time for us to take action. We're not asking for anything new. All these promises have been made for decades, if not centuries, on gender equality, and we must do our part collectively together. And I'm very thrilled that the conversations have led us all to the same place of really finding solidarity in each other, but also really catalyzing and sparking much more action. So I'd like to turn it back to the organizers. Really delighted to have been with all of you, and let's just keep this as one of many conversations as we continue to do the important work. And congratulations to all of you for forming this community and growing it, and just really doing the important work that you are doing day in, day out for global health everywhere.
Thanks, Rupa. Thanks, everyone. It's been great. I'm quite honored that we have so many listening in on a late Friday afternoon from Oslo. It's, of course, some of you are in other time zones, but still. Thank you so much. Have a great weekend, everyone. And stay in touch.